Hello, everyone. Thank you so much for staying after 5 and hearing this presentation. And I really want to thank the committee for having such a well-organized conference. It's a pleasure to be here in such a beautiful city. Yes. And I would like to present today about my work looking at a comprehensive sexuality education program that took place in Mexico City and exploring how intimate partner violence can be prevented through sexuality education. And the first thing I want to say is that this is a co-produced study. So from the beginning, all of the partners were a part of every stage of the planning, defining research questions, protocols, all the way through analysis. And the implementing organization is International Planned Parenthood Federation. And their local affiliate is called Makleff. It's a community-based organization in Mexico. And then the London School of Hygiene. And in terms of full disclosure, I was a staff for 11 years at International Planned Parenthood Federation while I began my PhD. So there was already kind of space to work together. And in addition, I had already worked with Makleff closely for 11 years. So because of this, my position within the three organizations, we were able to jointly develop and design the study. And just to give you a sense of what co-production means, from my perspective, it's that not that everyone has to be fully involved at all times, but that you define who will do what, who will be a leader in which phase, and that you can check in with each other along the way. So this just shows how closely we worked at key moments, particularly in the planning phase, but in the implementation, it was much more the local organization and London School, myself, and then the IPPF, which is the regional office, was less involved. And our objective was to examine how comprehensive sexuality education may contribute to violence prevention among students. And I emphasize the how because we did not attempt to measure violence that was averted. We did not try to quantify it. We tried to understand how change is happening, how young people are experiencing this program and how they may change. But we do know from the literature that violence can be prevented. So now it's time to really think about what might work in different contexts. So to give you a little bit of background, so sexuality education, there is evidence that it can prevent, that it influences a wide range of outcomes, and that it's more effective when it talks about gender and power dynamics. While we know it could prevent violence, the very few studies of sexuality education actually look at violence prevention outcomes. Usually they look at sexually transmitted infections or pregnancy prevention, contraceptive use. So this is attempting to fill this gap in the evidence base. And in terms of partner violence, to give you a little bit of background about that, the World Health Organization defines it as a behavior within an intimate partnership that creates harm, and that could manifest physically, psychologically, or sexually. And Lori Hygiene has, since I think it was in '98, developed the ecological framework to talk about how violence manifests. And so the causes of violence and the manifestations of violence occur at many levels. So first of all, the individual level, but also within relationships and within communities and within society, and that's where social norms that come in, and that social norms are one of the underlying causes of violence, and in particular, gender-based violence. And so one of the things that has been a lesson learned over the last 10 years of programming is that the programs that are more likely to have an influence on preventing violence adopt a gender transformative approach, which means that they're explicitly trying to shift gendered norms and social norms and beliefs. And that's what we refer to as primary prevention, because you're trying to prevent violence before it occurs by changing the underlying causes. So the particular intervention that I'll be talking about today is comprehensive sexuality education, and it's comprehensive in that it talks about a range of topics. It is not just information about pregnancy prevention and sexually transmitted infections, but also talks about relationship skills and communication and gender as a cross-cutting theme, and has a lot of critical reflection processes, It's about 20 hours of content that are delivered over a full full semester, and it is delivered by trained health educators. And I think this is an important point. It's not the teachers in the school, but we have experts from an NGO who are young themselves but are trained, that they come in every week and deliver the intervention. And they're delivered in groups of about 20 students. So to tell you a little bit about the context, this took place in Mexico City, which is a large city in a large country, and very much unlike what we were talking about earlier about the population in Japan. It's a very young population. 40% approximately of people in Mexico are under 20 years old. There's also very high attendance in schools and quite high levels of intimate partner violence. About 43% of women say that they've experienced partner violence in their lifetime, and about 33% say they've experienced violence in their current relationship. But the legal framework does support access to sexuality education. So because of this context, using sexuality education in high levels of schooling it gives you a chance to reach many young people and deal with a very important and pressing issue. So the study design was based on a theory of change that we collectively developed at the beginning that allowed us to articulate our hypotheses and assumptions. And each of those hypotheses was then explored through different data collection methods. So it was a longitudinal quasi-experimental design, but in a very small way. We had one school, and we had a morning program and an afternoon program. So we randomized with a coin toss to one program was the intervention group and one was the comparison group. And we did baseline endline surveys, focus groups, and interviews. And they were both one-time interviews, but also longitudinal. So we talked to students throughout the whole intervention. And the purpose of that was to see how they experienced it throughout, and if there's any moments that were moments of change that were particularly effective, and what their process was. So it's not, we weren't interested in their satisfaction as a whole, but actually their experience within the program. And we collected data not only from the students, but also from their teachers and the health educators. And we had local ethical approval as well as through the London school. And this was at a state-run school, a public school, that is a technical school. And so that means that it's studying automotive or food preparation. And it's in the southern part of Mexico City, primarily lower and middle income families. And it's a huge city, so just to give you some context, students often travel up to 2 hours to get to school every day. And this particular sample for this study, students were 14 to 17 years old. We had about 50-50 split between men and women. We got informed consent and parental consent, and we did the questionnaire with about 157 intervention students and 120 comparison students. And from the intervention group, we then have a subsample for the qualitative data that I'll be focusing on today. And there were 47 participants who are students, 5 teachers, and 5 health educators. One thing that's really important to note contextually is that just as we began to gather our data and start the intervention, there were 2 very significant earthquakes in central Mexico. And so schools closed indefinitely. We had no idea when they were going to reopen because there's only limited building inspectors, so you can't get to all the schools in a city of 20 million in a few days. And so we didn't know if the research would continue, and we didn't know if the intervention would continue. Ultimately, the school reopened after 3 weeks, so we had to shorten our intervention, and we lost our data collection moment. We lost some time that allowed us to do that. And so some of the intervention group data is okay, but for the comparison group, we had to wait till after the earthquake, so sometimes 4 weeks had passed. So basically, the data collection for the survey in particular was disrupted. And a few comments about this that may be relevant to people, but because I think all of us work in contexts that are at risk of natural disasters, especially in an era of climate change, that when there are natural disasters, research naturally becomes a lower priority. So people are worried about their emotional health, they're fearful, they have other concerns. So maybe the school might not have prioritized the study as much as it would have otherwise. And in this case, our quantitative data had very questionable validity. I had to end up throwing out the comparison group altogether. But I did find that the qualitative data were very resilient to the earthquake. And one reason for that is that you can ask questions and find out more about if the earthquake did influence their experience and how. And you can talk and kind of figure it out, and you have the space to do that in ways that surveys that are pre-designed won't necessarily allow. However, when you lose your quantitative data, I think the perceived rigor of the study will be reduced. So that's one of the negative things that happened related to the earthquake in terms of its influence on this particular set of data. So now I'm going to share some of the findings from the qualitative data, again, because my quantitative data are not valid. And I'll be talking about them in relation to this ecological framework. So I'm going to talk about some of the primary prevention outcomes, and those, again, are looking at addressing social norms and individual beliefs. And the way we looked at primary prevention, what we found was that sex ed facilitated critical reflection that helped trigger shifts in beliefs and attitudes and behaviors. And in addition, so that works in terms of thinking about social norms as well as at the individual level. And then I'll be sharing a few quotes that talk about secondary prevention, which is addressing violence if it happens. And the way that that happened in this particular study was encouraging care-seeking behavior, also building assertive communication skills, and preparing young people to intervene in violence if they saw it in their community. So I'll be sharing some quotes that illustrate each of these. And then the secondary prevention, just to point out, is more at the individual and relationship level. So it's addressing the violence that is occurring in your surroundings, in your life. So to give some examples of the primary prevention of violence, one of the important findings was that young people didn't know what violence could look like, and some things that seemed very normal, they didn't realize could potentially be violent behaviors. So we used a tool that's called a violence thermometer, and that has like a thermometer, but it shows different types of violence from kind of small things to very significant things. And the young people used this tool and took it very seriously. So, for example, this young man said, 2 or 3 times I examined it. I read each of the types of violence listed in the thermometer, and I wanted to see if any of them had happened to me. And many young people told us that they did this. They really made them think about their own lives and think about whether they were experiencing negative manifestations in their relationships. Another thing that is related is that young people thought about things like jealousy and possessive behavior and changed how they felt about it. So one young man says, I used to say that if they weren't jealous, they didn't love you. Things like that. But after the course, now I think jealousy is bad, because if you trust someone, why are you going to be jealous over them? And this was a very big shift that was very common. I mean, I would say that most of the students we talked to said something that reflects this concept. And then another young woman says that the facilitator made it very clear that if your partner loves you, they would accept you as you are, and they wouldn't tell you, don't dress that way, or I don't want you to talk to him. And they started to recognize this as a type of violence. Another thing that we found that was a primary prevention related were shifts in beliefs about sexuality. So a number of students told us that they began to accept their own sexuality. So this young woman says, the course helped me reflect and realize whether I was bisexual and that I was born this way and this is who I am. And then another young man who's bisexual said that he received less discrimination from classmates that he thinks was because of the course. So he said a classmate used to say gay people disgusted him, but after the course he didn't think that way anymore. He changed his way of thinking. And this, of course, relates to also discrimination relates to violent behavior, because homophobic discrimination is another form of violence. So to give some examples of secondary prevention of violence, young people told us about how they were more prepared to respond to the violence around them. So this young woman shared, we told our friend that she should leave her emotionally abusive boyfriend, that she should tell his mother about his threats. Because of the course, I already knew how I could help. And this young woman also said that the course left her classmates with a clear idea of what was going on in their relationships. So they decided to leave their relationships, and because they recognized that the possessive behavior in their relationships was a kind of violence. So these are things that show young people taking initiative and making concrete changes related that they directly attribute with their words to the course. Another thing that I think is important, not just for violence prevention, but for health promotion, is that young people became very much more comfortable talking about sexual and reproductive health. So one young man says, before the course we were embarrassed to talk about it, but afterwards we understood that it's like any other thing, and now I feel fine talking about it. And this also served them in their relationships. That also translated, many of them told us, to being able to talk within their partnerships about things that would have been embarrassing beforehand. And this is related to these assertive communication skills that they also developed through the course. So one young man said that because of what he learned in the course, he was thinking about it, and he decided to talk to his girlfriend about her controlling behavior. So while the women I mentioned earlier said they left relationships, they also realized it's possible to negotiate within a relationship and address the behaviors that may be problematic. And then something else we saw commonly was that young people learned about their right to access services, and this is another finding that is definitely not only useful in terms of violence prevention, but just in terms of creating rights-holding young people who are able to act on their right to health care. So the health educator in this case shared that after the course, the students began to talk about their right to get services. And also, we did see that they began to seek services. That may have meant going to talk to the health educators, such as this young woman who said she went to the health educators to get help so that her mother would begin to accept her sexuality. So that's sort of a large range of the types of findings. These are illustrative quotes, but they talk about the key concepts that came out of the interviews and the focus groups. Like all studies, the study had limitations. First of all, our participants were volunteers, and that means that they may be different than the ones who didn't choose to participate. In addition, they knew us. We were there throughout the semester as a research team and as an implementing team. So they may have told us more stories or changed their responses because they had interacted with us throughout the semester. As I said earlier, we did not directly measure violence mitigation or prevention. We looked at how young people were shifting. And we also, the furthest we went was 2 to 3 months after the intervention, but we don't know about medium to long-term change. And unfortunately, because of the small size of the intervention, we were not able to intervene with parents or teachers. But of course, you would think that that would intensify the results if you're working within the whole ecological framework. And then the earthquake. So to summarize the finding, we found qualitative evidence that comprehensive sexuality education can contribute to violence prevention through 4 of these main themes, which I believe, even though different contexts may have different programs that are contextually specific, these seem like themes that could be useful globally. That facilitating critical reflection about sexuality and gender and social norms is something that has been found in cross contexts to help with violence prevention. And that promoting assertive communication skills and peer support is also a way you can contribute to this. And then encouraging care-seeking behavior. So young people knowing it's their right and choosing to seek care. We all know that there are barriers to adolescents in particular seeking healthcare in general and sexual reproductive healthcare in specific. So this, by encouraging that behavior, that's a way we prevent. And I think most importantly, the person who delivers the curriculum is incredibly important. The implementer has to be well-trained and supported, and I think this raises the policy question of when we ask teachers at a school to deliver a sex ed curriculum, think what it would take to get them to be able to deliver these critically reflective discussions about taboo topics and support young people in the process. It's a big ask. And so I think in terms of thinking about policy, thinking about what training is needed and how to support who's implementing the sex ed. And I just want to talk a little bit briefly about the utilization of the findings. So on a programmatic level, we're already using the findings to improve the program at Makleff. And also because International Planned Parenthood Federation is a global federation, there is a lot of opportunities to share learnings within that network. And I want to point out that what I said on my first slide in terms of co-production, because of the co-production approach to research, they defined the research questions that mattered to them in the field. And so we were able to ensure that their questions were answered and then put to use. And so I think for us, one of the ways of ensuring the utilization of findings was ensuring that they were involved throughout the process and equal partners. And then in terms of policy, there's a new government in Mexico that's favorable to sexual rights, and the findings of the study, MexFam intends to use them to advocate for the scale-up of sexuality education for violence prevention. And I think on a policy note, there are a lot of critics of sexuality education, but almost everyone says that preventing violence is good. So in a sense, this finding that sexuality education can help prevent violence could help make it a more acceptable intervention that is somehow more palatable to people who think that sexuality education will make people more promiscuous, or there's a lot of negative and false claims about sexuality education that we hope this can also help mitigate somewhat. And again, the co-production, we knew we had this advocacy objective, so this was not intended to be, we knew that we hoped to find findings of the study that helped us advocate for scaling up sex ed. And so because we knew that from the beginning, we were able to ensure that the outcomes answered questions that were policy relevant and program relevant, basically. So we designed this with audiences in mind. This wasn't intended just as an academic output. And I want to acknowledge the school in Mexico, as well as the health educators and teachers and students. The participants shared so much about their lives in so much detail, and we hope to do justice to that and continue to analyze these data and get these findings out. And then my colleagues, including my PhD supervisor, Cicely Marston, who's also a co-principal investigator. So yeah, thank you.